Arizona, currently in Michigan right now.
Say that again, from Arizona and what?
Currently in Michigan right now for clinical rotations.
Oh, awesome. Great. It's nice to meet you, Nathan.
Nice to meet you.
Travis.
I am a personal trainer and professor of exercise science at Jefferson University in Philadelphia. And I've come across your work through the Level Up initiative and been like blown away by how awesome you are. So I'm excited to get to chat with you today.
Thanks, Travis. And there are some people at Jefferson in the med school doing some good stuff with medical humanities. So that's awesome that you're at Jefferson. Great to meet you. Hi, Paul. We've met before. Yes. Daryl.
Hey everybody, my name's Daryl Wisman. Like you were saying, I'm kind of away as well. I'm up in the Poconos with some friends. So I'm on cellular data, and I hope that my connection's coming through okay for now. But awesome. I'm a student physical therapist at Arcadia University. I studied philosophy and public policy at University of Delaware as an undergrad. And our senior seminar was actually on death and dying in context of like euthanasia and death with dignity. So I'm really curious to kind of hear more about your work and to have other physical therapists in the room to hear about their perspectives.
Great. You're in the right place. Nice to meet you, Daryl. Joseph.
Hello, I'm Joe, second year physical therapy student at Simmons University in Boston. I think just like Travis had mentioned, or maybe it was somebody else, but I'm familiar with some of your work through the Level Up initiative. I have your book and I'm starting it soon, so I thought this would be a good way to preface that.
Totally. Glad you're here, Joe. Rachel.
Hi, everyone. My name is Rachel Noble. I'm a recent physical therapy grad from the University of Delaware. I'm currently doing a sports residency there. Go Blue Hens. I am also familiar with your work through the Level Up initiative. I've read Afflicted, just not your most recent book, so I'm looking forward to learning a little more about that and hopefully ordering that soon.
Awesome. Hi, Rachel. Marilyn.
I'm a physical therapist and I live just outside of Seattle, Washington, and I have a clinic in my home.
Oh, that is amazing. So are we in the same time zone right now, Marilyn?
No. Oh, wait, you and I are. Yes,
Yes,
because you're in
I know.
California.
Yes, yes. It's nice and early for us. Logan.
Yes.
Hey, Nicole. So my name is Logan. I'm actually a chiropractic student in St. Louis. And haven't read any of your books, but I have watched the talks on Level Up that you've done and really appreciated your perspective. So excited for today.
Yeah, glad you're here, Logan. And last but not least, Quentin.
Hey, how we doing? Everybody just calls me Q. If you call me Quentin, that's foreign, very foreign ground, but that's okay. Maybe that just goes along with what we're going to be doing today, just getting very comfortable with the uncomfortable. So that's probably okay. But I'm a physical therapist, own and operate a clinic in Chapel Hill, North Carolina.
Awesome. Wow, you guys are from everywhere. How fun. Really, really glad that y'all are here. So Chris, you had initially asked me what my preference was, and I don't know. I think maybe your suggestion of kind of like initial reactions or thoughts or things that struck you that you want to talk about might be the best way to go, just kind of organically.
And maybe before that, I'd be interested in like the rationale or the reason why you wrote this book, and then maybe how, because I know a good amount of people have either not read it yet or are planning to read it. So I don't know how many have initial thoughts, but maybe why you wrote it and then how you see it differently than like Afflicted, and if there's any, changes in your beliefs or thoughts from like writing that to finishing this book.
Yeah, that's a great question. So I initially wrote this. I wrote it with my partner at the time, Sean, who was going through, he was a resident at the time. So knew him since med school. And so I had written Afflicted already. And my publisher had asked if I wanted to write another book, and I was like, no, I'm not interested. Like, it's really hard writing a book. That was a lot of work, like, very intense. But after one of Sean's shifts one time, he said, God, we have to write about the fact that in healthcare, we are not talking about death and dying, because he had just given chest compressions to this man dying of cancer who was in his 40s, who, I mean, he was dying, right? Like, everyone knew he was dying, but the default in medicine, if you don't say otherwise, is to intervene. So he was like pretty traumatized, having given chest compressions on someone who basically seemed already dead, and doing that for like 45 minutes to an hour in front of the guy's wife and kid. And he was like, I wasn't prepared for any of this. No one talked about it in medical school. This is just what we do. He's like, people need to know about this, like what's going to happen to them if they don't make conscious, specific decisions about what they want the end of their life to look like. And he's like, we need to write a book that's like narrative about this, because a lot of my scholarship is in end of life care. We can talk about how I got there if you'd like. But so, I had responded to my publisher's email, and I was like, well, I don't want to write another book. I guess if I were to write one, I'd want to co-write it, and I'd want it to be about death and dying and be pretty narrative and not academic, like Afflicted was really academic. And he was like, perfect. I wanted to see if you wanted to write a book about death and dying that's in the Essential Knowledge series, which means it's like for lay people and not academic. I was like, damn it, fine, I'll write it. So it was kind of serendipity. And in the book, it's kind of interwoven between what Sean was going through as a trainee and my own experience with my mom who died, which I talk about in Afflicted. While we were writing the book, my dad got diagnosed with terminal gastric cancer. And so we're writing the book as we're trying to navigate end of life again with my dad, and running into all the things we're talking about. And at that point, Sean was becoming a palliative care, hospice and palliative care doctor. All my scholarship is in end of life care. And we still couldn't do it right. Like, my dad we called 911 when he was dying, and I had to beg the paramedics to stop giving him chest compressions. And it became really real. Like, you are not going to die well in American medicine unless you take a lot of steps. And so the book was this exploration of like, why is this happening? What is it about our culture that can't acknowledge death authentically? And what are we doing in healthcare when we're training PTs and OTs and PAs and doctors, where we don't explicitly talk about death and dying, and we just let like the machinery of medicine take people on their conveyor belt. And in those of you who read the book, there's all sorts of reasons: cultural, historic, contemporary, technological. So, and I just think we don't have enough conversations like this where we get people to become mindful of medicine's default. So that's where it all came from, I suppose. And I really am curious to hear from you all, what you've seen about death and dying. Has it been your own families? Has it been in training? Did your training prepare you for this? Do you sometimes see patients where you're like, why are they getting a PT consult like this? So I would love to hear that. And I would love to talk about the fact that most PTs get reimbursed, almost all of them, if you can show, I never remember the term. It's like restoring functional, what's that term y'all use, Chris?
Return to baseline, you mean?
Yeah, return to baseline. And where I think PTs would be amazing is in the hospice setting, where it's like, let us train you and the caregiver how to get you up out of bed to use the bathroom, or still engage in meaningful activities until the very, very end. But that's decline. And there's no restoration of functional status. It's helping you decline in a meaningful way. There's no reimbursement structure for that. And so were
There-
you guys, go ahead, Paul.
I was going to say there is maintenance care allowable underneath Medicare.
Mm-hmm.
You just have to know how to document it, right? I mean, because obviously it still has to be reimbursed for you to be able to do that work, right? To at least some degree. And so there are maintenance programs. You just have to be able to kind of show what you're maintaining. And even if they're declining, you're still having to document how you're doing that. We just don't have great standard measures that have any research of this is a valid level of regression, right? And so now it becomes somebody's opinion, right? Of, well, did you maintain them enough? Or was that regression looking like, okay, it's too fast of regression and we're just going to stop paying now, right? So not many people do maintenance work because it really seems to be up in the air and there's not kind of this standardization of it. There are some organizations that do it. It's just, there's very, very, very few.
Yeah, Paul, that's encouraging. I think one of the issues is, the hospice benefit is under Medicare, but within the hospice benefit itself, which kind of takes over your payments if you enter hospice, there's no PT/OT under the hospice benefit specifically, but maybe what you're talking about is like a loophole. We could eventually get there. But if you ever see PT/OT on a hospice care team, it's usually because they got a grant or they're doing some kind of demonstration project. It's not the default. And I think like you guys intuitively know, you understand the lived experience of illness. And how do we keep people moving and engaged while their life has changed so much after an illness or injury? And yet where your expertise, I think, could be so critical, we'd have to find a loophole to get you to even participate. And I don't know, like, do you feel like the ethos in PT education really is this restoration of function or return, or like, how would you guys describe like the philosophy of PT or PT training?
I think that's going to vary wildly based off of where you go to school.
Mm-hmm.
Very, very wildly. I mean, because some is pure, very, very little baseline, like prior level of function is basically, my parlance is shit, shower, and shave, right? So if you can do those things, we've basically got you at your functional level, right? While other things are very focused on the very high end athletic model. So within that full scope, right? So you kind of have, are you a functioning human being or are you a high level athlete, right? And it runs anywhere within that gamut. But there's really, I went to school well before these people. There's no death and dying talk. There's no end of life type of a focus. It was always progress towards another direction, right? And that was the focus when I went to school.
Yeah, thank you, Paul. So progress toward something, right? And that something usually isn't the end of your life, I would suspect. Has anybody else had death and dying, grief, bereavement, other than undergrad, but in PT training?
I can jump in there for a second too. So I'm a second year Arcadia DPT student, and then we are wrapping up a non-traumatic spinal cord injury and non-progressive neuro condition unit. And so we've been having the conversation about restoration or compensation in that context. And like, are we going to get the person back to their prior level of function, or do we need to figure out compensatory ways for them to do things? If they can't use their legs, like obviously they're not going to get up and walk around. So what kind of equipment and whatnot can we use for that? But we also had a unit on hospice care and palliative care and physical therapy in those settings. And it kind of flipped my perception of physical therapy on its head, because as you're suggesting, like we're generally thinking about restoration, or I can't tell you how many times I've written return to prior level of function. And sometimes that's not the case, that I understand, at least from the kind of academic perspective. Not been in those scenarios necessarily yet where there's a patient that's not going to return to that prior level. And I've got to think about, how do I, as a physical therapist, provide services that will meaningfully improve their quality of life, even if that means that we're not using necessarily like restorative kind of ways to get there.
Daryl, thank you. That's really, really helpful to understand that. It would be interesting to maybe some of you with those philosophy backgrounds, like to think about what is restoration, what is wholeness, and like maybe restoration is bringing meaning at the end of life. Like maybe that's still healing. Maybe that's still restorative to give someone really meaningful 4 or 5 weeks, 4 or 5 days at the end of life. You know, is restoration really return to prior level of function, or is restoration something different? And can we start shifting what we think healing is and what we think restoration is? And can we get healthcare practitioners to all participate in that? I'm looking in the chat at what Daryl put. One of my favorite books, if you haven't read it, When Breath Becomes Air. And one of my favorite quotes, thanks, Daryl. The physician's duty is to not, did I put this in the book? I might have put this in the book. I don't remember.
I haven't read it, so I don't know, but it's a quote that stands out to me.
I think I did. Whatever. The physician's duty is to not stave off death or return patients to their old lives, but to take into our arms a patient and family whose lives have disintegrated and work until they can stand back up and face and make sense of their own existence. Yes. So I use that quote with my medical students all the time. And my question to them is this really your job? To take patients and their families into your arms whose lives have disintegrated and work until they can stand back up and make sense of their own existence, right? And I'll get some medical students who are like, hell yes, yes, that's what I'm called to do, right? But then I get a fair amount that are like, that's a social worker's job. That's the chaplain's job. I'm all about interprofessional education, interprofessional team, where you've got experts who can do this. But I deeply believe that if you're a healer and you are a healthcare professional, you're at least dipping your toes in that, or helping direct the team and orienting them towards that, because the default is not that.
Yeah, I operate from I call them my ABCs. I'm looking for, how do I give somebody agency or autonomy in their world? How do I bring belonging back to them? Because usually, like even in an athletic setting, you've lost the team, right? Because you're typically separate from the team. And so how do I get them back practicing with the team? They can do their rehab while the team's practicing, but they're in and belonging with their group. And then I want them to have whatever their cause is, whatever brings them joy. I want to return those things to some level. The end of life would just be reframing that for, they still have some agency, they still have belonging, bring them back with their family, having the family and other caregivers be part of that. Their cause may now just be to die well, right? So now I have a new definition, but we're redefining those same basic frameworks. We're just getting to redetermine what those are for the person in their current existence, right? And I think that's kind of where we have to kind of think, is that broader picture of what am I really trying to do? Because my argument is, when a patient comes to me in pain, it's not the pain that they want to get rid of, right? I fully believe that they've lost a part of who they see themselves as, and I've lost my agency, or I've lost my belonging to a group. I used to go to my gym and I can't go to my gym anymore. I used to do this activity and I can't do that activity anymore. So that was my core group of people. I've lost belonging. So they're really looking to return to something other than get rid of my pain, or that activity really just represents a version of themselves that they see themselves as. And so I'm trying to do that for them, not really get the need to feel better. So it's, how do we broaden those scopes? And then maybe that brings in that end of life care back into that realm of what we're doing as practitioners.
I want to emphasize what Paul just said right there, in case you missed it. Patients don't come to me necessarily to just get rid of the pain. So Eric Cassell in the early 80s was one of the first physicians to write about the difference between pain and suffering. So he's got a book on it, The Nature of Suffering. And he also has a shorter article that he wrote in the 80s. It's crazy to me that it took until the 80s for a physician to write about the difference between pain and suffering. But what he says is what Paul's talking about right here. The pain only matters if it disrupts my life world, my lived experience. If the pain, thanks, Chris, if it doesn't mean much to me, or the fact that like sometimes pain doesn't cause suffering. Think of childbirth. That causes joy, even though it's like incredible pain, right? So the meaning we ascribe to pain is the only thing that matters. And if the meaning means it separated me from my team, or I can no longer run and I'm a marathon runner and that's my identity, that's why patients come to practitioners for restoration of my identity, my role, my occupations. And so you guys are involved in meaning making and restoration of meaning. You guys are philosophers, whether you know it or not, right? You guys are philosophers. So at the end of life, how do you all restore some things that are not ameliorating pain or getting someone back to prior function? Imagine the training you all could do. The bulk of hospice work is nurses coming in once a day, a couple times a week. What if you taught the family how to do safe transfers, and like that stuff restores dignity and connection at the end of life, which is like the only thing I think that matters. I don't know. And you guys could be doing that. So that's a really important point, Paul. You guys aren't treating pain, you're restoring something much, much bigger than that.
Going off that pain point, I've been really frustrated the past few weeks because I'm in an inpatient rehab hospital, and in the EHR, you have to document their pre-treatment level of pain on like a numerical pain scale. What would they consider acceptable level of pain, and then post-treatment. And the first few weeks, I kind of like made up the levels because I just felt like a dick asking these patients, like, how's your pain right now? What's acceptable? And then at the end of the session, it just felt so much like overkill. And it's like, then my instructor caught on and was like, you have to ask these. But to me, it's like, what is the goal? What do we like? It goes back to like, you're increasing attention to the thing that they probably don't want to focus on. And so I've really struggled with that the past few weeks, where it's like, how do I, get around this, but I really can't. I don't know. It's been really frustrating.
It's a pure cover your ass. And I had this experience. In one of my prior businesses that I owned, we didn't ask about pain, right? We did it at the initial eval, but we didn't ask about pain session to session, right? We just weren't going to focus on pain. We were focusing on other things. They're coming in. And so, can we bend more? Can you do this? What are you doing more at home? Whatever the focus was, right, for that patient. But I had a therapist that a patient reported to the board because she said she hurt me in session. And when she went to the board asked, there's no note of what the patient's pain level was prior to, during, when you were doing your manual manipulation, and then after, what their pain was. So we don't know, and we have to take her story, and that person had to do 30 days community service for that to the board. So we had to go back and add it in as a protect your ass, but our focus was, that's not where we want to live, is pain, 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 pain. We're trying to get you to focus on the things that you can do, not what that is. And that actually bit us.
That's so interesting. So, Chris, when I think about, okay, so two things. Paul's totally right. And I think it's something else too, because Chris, if I'm your patient in the acute rehab, and it's not necessarily the quantification of my pain that I care about. Like, I care about, did Chris connect to me in a way that I trusted him? And then was I able to do some stuff I thought I wasn't able to do? And now I've got this more sense of like autonomy and agency, and maybe I can get better. That's probably what I would care about as a patient, not what does my pain feel like over 24 minutes together or whatever we have. And so I do think that, yes, the pain levels need to be documented for this cover your ass medicine, which is what most of us are always doing, but also quantifying suffering. Healthcare would much rather quantify suffering and put it in some like objective, sterile number than to be thinking about, talking about, and documenting the unquantifiable, this person is suffering in front of me. Does this make sense? Like we want to deal more with like numbers and scans and pain and interventions. And that's what like Afflicted is about, like how we over quantify the unquantifiable human experience. And so I think, in healthcare, it's twofold: cover your ass so you don't get sued. And also, like, this is easier to talk about. Let's be applied scientists and technicians. Let's not like walk into people's existential suffering. That's not what we're here to do. And I think it's like a symptom of it, Chris.
But he could frame that in his head when he's asking about that, because the question is what's acceptable, right? As part of those numbers. So I'm just getting an idea of where you are, right? Is this acceptable to you? But you could explore that as part of your course of care with that individual, right? So, okay, so what's acceptable? Well, a 5 is acceptable. So why did you choose a 5, right? And then actually get some pain education and helping them understand that pain may not equal harm and some of those other kind of things. That's an opening and a broadening of a door to access some of that. So how does that pain and how is that suffering? How is that affecting our ability to go do our transfer that we're about to go do, or that it could lead to a longer discussion. You just have to reframe that in your brain. Then you don't feel like you're just checking a box and doing something that's bullshit. You maybe can utilize that to expound into your care with that individual.
Great point, Paul. I think it is a personal approach like that. Do you guys see, is it a straw man argument to say that there are people running around like technicians who are just doing the check boxes that Paul talked about? Or do you see a difference between like your colleagues or your peers where some are kind of doing this functioning in the technician role? And then there are others who might be like you all on this call who are like opening up and expanding a different approach to care? Or do you think everybody's more along the line of, yeah, they want to engage with patients and not be technicians? And I just want to hear from you because you guys are on the front lines. Or are there some colleagues and peers that are like, not, they want to be a technician?
I'll talk. I personally will say that you're going to see it's human existence. You're going to see somewhat of a normative curve based off of what we're questioning, right? We're going to have some that are doing good jobs that are going to be over here and living much more in that interpersonal. You're going to have some that are pure technicians, and we're going to have some, and which I think is the most, define the time of day, how fatigued, how many other patients, all that other kind of stuff, right? So when I'm feeling good, I'm well rested, and I've got a lower caseload, I can involve myself a little more. When I'm really stressed, I'm having this, I haven't eaten, it's right before lunch, I'm kind of hangry, I just want the check boxing to get through with the session, right? So we're going to have those in the middle that are going to be both. And I think we're going to always have that because we're human, right? And so we're going to have that, but there's going to be a shading of the side that we want to be moving to. We might want to, if we're going to say the right side is the side of the curve that is caring, we're trying to shift it right, but we're always going to have a little of that normative.
Yep. I think you're right, Paul. I think you're right. Anyone have experience with end of life, whether that's with patients or experiences in your family and things you've taken away from that, and how that might change your approach as a physical therapist? Maybe you've never seen anyone die or get close to death.
I'll talk because one of the reasons I wanted to be on this is I had end of life with my uncle, right? Which was really at that point interesting to me in that he went from, I don't want any end of life care, I don't want all this other kind of stuff, right? To where when the doctor walked in and said, well, your kidneys are failing, this is this, do you want these things? And he went, hell yes. Right. So at that, when it was really the critical thing, even though he's written all the papers, it's really easy to write the shit on paper. But when you're suffering and feeling it and they offer things, people will grasp.
Yeah.
Right. And so my dad was like, are you sure? Because we have this other stuff. We were there to try to help his end of life. Right. And he's like, yeah, no, I want it. So that I saw that when we're really at that moment, sometimes it's hard. Right. Yes. And that for that individual to release and to let go, even though they conceptualize it, it's hard. And then with my dad, he died. He did not want any end of life care. He died on the floor, but the EMS resuscitated twice in the ambulance and then put him on what he did not want. They put him on vent and everything else. Right. So when I get to Houston, I have to pull him off. Right. Because I'm the one that has to do that. And that was hard.
Paul, I hate that you went through that. And I think so many families do. where they have to make this terrible decision that feels like an active decision to let someone die when your dad would have died anyway. And in the hospital, at our hospital, we're trying to change the language to allow natural death instead of do not resuscitate, do not intubate. It's allow natural death, which is what you did for your dad. He would have died at home. He probably did die at home on the floor, and he got brought back. And medicine and the first responders didn't allow for natural death. And I think what people don't know is you're going to get resuscitated at home unless you have an orange do not resuscitate form displayed in your house, like on your fridge or on your front door. Like people don't know that, right? Like you have to do active things to stop stuff that you don't want to happen to you. Very few people have those orange do not resuscitate forms. So Paul, you had to do something that felt like actively, some families feel like killing their loved one, even though that's not what's happening, which is more painful for you, more traumatic for you, more traumatic for your dad, because that's just the way medicine flows. Like that's what's going to happen if you get caught up in it, the stream of medicine, which is really, really hard. I wonder, in your uncle's case, could the physicians have presented those options to him differently so that he wouldn't have chosen active intervention when it wouldn't have helped him?
Oh, yeah. I mean, they could have said, this is going to do this for your life. It might be another week, it might be another 2 weeks, right? Is there things that you're wanting to accomplish in that time frame? Laying here in the bed, you're not going to get anything up, but like you get to see somebody. Do you want us to call somebody and do that? Then maybe this is a rational choice based off of your priors, right? So your prior wishes were this, we're offering this, but only if there's a rationale for this, because it's not going to cure you. It's not going to give you anything else. It's just going to buy you a little more time that you might be able to do something that you wanted to, but otherwise your priors were this. And I maybe we shouldn't be doing that for just a little bit more time that you're not going to do anything with.
I think that's exactly right. I think that often treatments are presented without all the information. Here's another chemotherapy. You might live 3 weeks longer. People don't know that. Here's another chemotherapy. I might be cured. That's what people are thinking.
Right.
That's what people are thinking. And we could keep doing dialysis. You'll be living probably for 2 more weeks, and you're going to be getting dialysis instead of at home. And actually, dying of kidney failure is a pretty benign death. Like it's not that awful. And helping people feel like you won't be in a lot of pain and you could spend some time with your family. So I think like the conversation ends at, here's your options. And what's really like what I've noticed, we have this pendulum swing in medicine of in the 50s, 60s, 70s, it was all paternalism. You're going to do these things because we say. So then we pendulum swing to autonomy. Let's give patients autonomy. Let's give them their options and let them decide. I think the pendulum went way too far past autonomy. And what we're doing is we're presenting patients with a menu of items and then letting them choose, even if they choose badly. We're like, well, they chose it. I gave them their options. They're autonomous. Without having the moral courage to be like, if you were my mother, this is what I would maybe want. Or, if you choose this, you can, but your life's going to look this way. And I'm worried you're still going to die. The conversations aren't going far enough. It's here's the menu items, choose. And I don't think that's helping anyone.
So to that point, if you like, do you have to present all the options, or would you not present the options that are not the most advantageous?
So I think clinicians struggle with that, Chris, like making that decision. Atul Gawande writes about this. Being Mortal is an amazing book if you haven't read it. And he talks about this. He talks about how he became a articulator of menu items. And then, so he does say, maybe there are some that have such minimal benefit that you don't present them, or you present them as this thing exists, but I would not recommend this for you. I think it's going to increase your suffering. And I think that that's still honest. You're not hiding options, but this is a huge debate for, and especially surgeons, right? Because there's always basically a surgical intervention you could do. You could, but if that is like a silly, irrational option, should we be giving it to people just because you can do it? What do you guys think? Like, if it's you, do you want all the options, or would you rather not hear about some that have very minimal benefit?
Yeah, I have an opinion on that.
Okay.
So I was going to reference a Tolga one day too, because of the story of his dad in that book. And I think what that hints at is having the conversations with patients to discern like what do they base their quality of life on, and like what level of function or what things are most important to them. And then I think that helps inform what the menu items are supposed to be, or at least it helps inform you as a physician or physical therapist or healthcare provider, how you can help frame and provide the information about those options and how they will affect what's most important to that individual.
I love that, Daryl. So that presupposes that a conversation happened where you understand values and goals, and then you shape those menu items according to those goals. So you say, well, Mrs. So-and-so, given that you said this, and this is your value, I'd recommend this, and I don't think these options align with your values. I love that, Daryl. My fear and my knowledge suggests that those pre-conversations aren't happening, right? Like you're getting rounded on by some specialist you never met, and they're giving you menu items and they don't know you or your values. But that's exactly how healthcare should be delivered, I think, Daryl. And I think we're so bad at having those conversations where we identify those values in the first place. But
What are
that's
your
what I wish.
thoughts, Nicole, of like, so this is, I feel like, been relatively largely talked about in PT as well, with like informed consent and laying out all the options. So if you're like a patient in a hospital, I'm just trying to picture like, what if every provider lays out all the options? Is that just information overload? Because you as a PT could be like, well, we could get you up and ambulating. We could, give you a cold pack. We could give you stim. Like there's unlimited options. And so it's like if the OT, PT, physician, like if everyone does that, is that just chaotic? Who lays that out? Is it just the physician?
Yeah, no, physicians don't get what y'all do. So I'm not going to leave it up to him or her to make those decisions personally. So this is why interdisciplinary team meetings, I think, are critically important. And sometimes they're happening, sometimes they're not. In acute rehab, they are for the most part. So I think those are critical. But I think you are trained professionals who, what is the point of you guys being trained? If I could Google all the PT options for myself and then pick one, what's the point of y'all who are like, no, in my professional opinion, this is what's going to work best for you? And this is why I think educating your guys' emotional intelligence, discernment, intuition matters, because you're bringing that to the situation too. Like sometimes it's my gut tells me this is the right thing for you. And so this is why I don't like when we split hard and soft skills. So the soft skills being your intuition, your gut feeling, your ability to authentically listen, to pick up on emotions of the patient. Those to me are hard skills because they start to shape your treatment plan. They start to shape your diagnosis. The good clinician knows things and feels things, right? Like I've talked about this in Level Up. And that's what I think you're bringing, that intuition and connection and emotional intelligence that might shape your menu options. So I want the living, breathing human PT who uses her expertise and gut feeling to tell me what's best for me instead of me picking something off of a menu you handed me. Does that make sense? Yeah.
Now, here's a question, Nicole, that I have. In like current medicine, we have replication issues, right? For some statistical issues, right? I mean, we could get into a philosophical aspect of Pearson's things and all these other things. Are those data points even real? And so the founding of much of our statistics is kind of inversely looked at as far as what the stats need to be, et cetera, et cetera. So given that level of uncertainty, right, how do we have good information to give patients at end of life where it really matters? That choice could be increasing suffering versus increasing deaths, because there's a lot of, I mean, we have a level of uncertainty that we don't want to embrace into statistics even going forward on our testing. Then that adds to the confounding errors that are there for what our recommendations are now going to be.
Yes.
Right. And so how do we navigate that mentally, would you say?
Such a good question. So I think evidence-based medicine is good and real. I think it's flawed, whatever, but I think it's good and real. Like, I want to know if someone's giving me treatment options, I'd want some data as to like how this is going to go. What we are notoriously bad at in healthcare education is comfort with uncertainty. It's one of the arguments for the medical humanities that it helps you deal with ambiguity and uncertainty. So I'm someone, and maybe it's just me, that I wouldn't care if you came into the room and you're like, we actually don't know how this is going to go for you at the end of life, for instance. Death and dying look different for people. And, you know, I think this might be the best thing for you. I'm okay with the clinician saying there's some uncertainty here. This is the human experience. I'm not going to pretend that we got control over it or know how this is going to go. I wonder if patients are a little bit more comfortable with ambiguity and uncertainty than we think. I don't know. I don't know. What do you guys think? Like, would you be okay with a clinician saying that? Travis, I feel like
everybody's different.
Okay, good.
I feel like everybody's different, right? And some people want to be reassured, and some people like they want their clinician to be really confident and tell them how it's going to go. And some people want to be told, here are the many ways that it could go. So I feel like you have to get a sense of that person. I think I froze a little. I feel like you have to get a sense of that person, but if you're meeting them for the first time and
yes. So Travis, you did freeze a little, but I think I gathered what you were saying, that it depends on the patient and kind of knowing what they prefer. And that's also contingent on having enough time to do that, which, you know, our healthcare system doesn't totally allow for that. So yeah, I think you're right. So Catherine Montgomery, she wrote this book, How Doctors Think, different than this one by Danielle Ofri that a lot of people have read. And she did this ethnography where she spent a couple of years in the hospital. I think she's an English professor. And she spent a couple of years in the hospital, like following these people around and being like, how does medicine function? What's its rationality? And in that book, she says, medicine is narrative through and through. Y'all just tell stories to each other. You write stories in the patient chart. You talk about anecdotes. You tell your colleague, this is what's going on. When you're at interdisciplinary rounds, you tell a story. And she's like, medicine pushes away the fact that it's storied through and through, pretends it's not. And she says, medicine is an interpretive practice. You guys walk into either the clinical exam room or the hospital room, and you interpret what's going on and what's the best thing. You interpret when you read the chart, etc. And she says healthcare likes to deny that it's interpretive and that it's interpersonal. And so she says, the more healthcare walks around and pretends it's an applied science, the more, she says, good clinicians know it's not. They might say it, but they know it's not. And she says, the more we present it as an applied science, the more we perpetuate expectations of patients that you're going to know exactly what to do, exactly how to intervene, and they're going to have the best outcomes. And when they don't, that's when there's an increase in litigation. They sue you because they say, you guys are scientists. You were supposed to know. You took enough scans. You ran enough labs. How'd you mess this up? When really, it's this interpretive practice that we're constantly improving with some of that data you alluded to, Paul. And if medicine did a better job of presenting itself that way, she thinks patients would have better expectations, y'all would have better expectations, and you'd come to this understanding that we're just trying our best. Chris is thinking.
I feel like it's moving in the other direction with like, I mean, you have these like TikTok and IG like doctors or healthcare providers that like make everything look super flashy and have millions of followers and like provide all these absolutes. I just, based off social media and kind of the immediacy of things, I think it's hard to do the opposite and slow down and provide uncertainty and go in the other
Chris,
direction.
I think you're right. I think something else is going on too with the TikTok advice and blah, 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 is this deep distrust of healthcare professionals. So this expectation that everything ought to be certain and easy. And then this, y'all don't know what you're talking about. I heard on TikTok that, why aren't you offering me that? And I think we're seeing a crisis of trust in professionalism. And with COVID, right? Like not listening to healthcare professionals about vaccines. I work with a lot of physicians who are very worried because they're getting patients who are like, you don't know what you're talking about. I don't know if it's affecting PT in the same way, but when you've got this overload of information you can get, and it's more than WebMD now, right? Like it's more than Dr. Google. It's social media and distrust and professionalism. So, which I think maybe causes professionals to then dig their heels in and say, well, I'm certain this is what the data says. And then we're getting even more entrenched in this gridlock of, well, I'm the expert and I know exactly what's right, and them not trusting. And then when things don't go the way they were supposed to in healthcare, see, we told you, y'all don't know what you're doing.
Is there a better, I mean, in your opinion or what you've seen, is there a better system like outside of the US that you think we should follow that does a lot of these things better?
So yes and no. I think part of this stuff is like the human condition. I don't think humans like uncertainty. We certainly have a very hard time with death and want someone to fix us, no doubt. But there are other healthcare systems, especially those that are, everyone has access to healthcare, the NHS in the UK, for instance, where not all options are given, in part because they're unaffordable. But I think there are patient, and you can't sue in the same way, right? Like litigation is not happening the same way that it's happening in the US. So I think maybe clinicians are more comfortable giving the best options and not some others because they're not afraid of getting sued. And at the end of life, there are some countries, I would have to take a closer look at it, but I've seen examples of in the UK, in New Zealand, in Australia, where you're not going to be offered the chemotherapy that has a 10% chance of extending your life for 3 weeks. Not an option, not presented to you. We're going to help you die well. So yeah, I think there are places who are doing it better.
So going to the dying well, I was rereading part of your book, and I think you said at the end, like, there is no dying well or dying badly, right? Did I read that
Yes.
right? So like, what are you defining right now as dying well?
So I do think there are good and bad deaths. But what I was trying to say at the end there was, if you want to die on a ventilator, getting pressors, and having someone do everything, even though I personally think that's not a great death, that might be good for you if you chose it. If someone had honest conversations with you and you were like, no way am I going to hospice, do everything. I think that's fine if it's your choice and not a result of a conversation that never took place. What I think is happening in medicine is people are dying that way because a conversation was never had. And so that was the default. So I don't want to say good deaths are always at home, no machines, with your family, intentional, reflective, good conversations are happening. I kind of think that's what I would want. That's a good death for me. But I don't want to prescribe a good or bad death. I just think it is morally unacceptable for you to die in a particular way because no one had the courage to talk to you about the fact that you're dying. That's a bad death.
I'm curious to ask somebody else can go. I've talked already.
I was just gonna say, Nicole, do you think the default, like in the opposite of this scenario, should the default be like towards a natural death, and then if you're informed, you can choose a different way? Or what are your thoughts on that?
I've never thought of it or put it exactly in that way, but maybe yes. But the problem is that defaulting to doing nothing, I think clinicians feel it is like morally reprehensible that we didn't resuscitate someone who would have wanted to have been resuscitated. That seems like I let someone die and I participated in their death. While I think it's probably better if they're 95 and dying of COPD, you should default to not doing anything 100%. I think people feel complicit in that death without realizing if they do resuscitate, they're complicit in extending and exaggerating suffering. But they'd almost rather do that than let someone die, I think. Daryl, you were going to say something too.
Yeah, I'm just curious if there's any model to have these conversations. And I'm thinking back to a lecture I had this past week on sexuality and spinal cord injuries. And there's a model called PLICIT, and that's permission. You've got to give the person permission to speak about sexuality. And then you provide limited information and then specific suggestions and then intensive therapy.
Mm-hmm.
And I'm just curious, like this is a sensitive taboo topic as well. If there's any kind of model like that for healthcare professionals to have these conversations around kind of giving those options.
Yes, great question, Daryl. So typically it's taught in medical school with a mnemonic called SPIKE, setting the stage, but it's the worst. I hate it. Don't look it up. I have a conversation. So I'm a trained like end of life conversations person. And there's a really great model that's out there. In Arizona, we have to call it serious life conversations. There's this political action group. They're the worst. And they think that like healthcare professionals are running around trying to pull the plug on grandma and murder people. And so we're not allowed to call it end of life conversations. We have to call it serious life conversations. Don't get me started. Anyway, so they've got a conversation guide that I think is really helpful and videos and all this jazz. So I will send that conversation guide to Chris and then he can send it out to you guys. Because I do think that even though prognosis, treatment, blah, blah, has to be left up to the physician, that there are some conversations that you all can at least start or set the stage. And one of the phrases I think that's really important is, I'm worried. I think that's such a good way to open the door. I'm worried. I'm worried we're not going to get you back to where you were before functionally. I'm sure you guys have said this before. So it could be that you're in interdisciplinary rounds or you're talking to the doc and you could just say, I'm worried that this patient is approaching the end of life. So that phrase works with patients. I'm worried about X, Y, and Z. It communicates, I care about them because I care about you enough to be worried about you, and allows you to say something kind of hard. And I think it's a phrase that you guys might find beneficial, not only with patients, but with the other care team, to get them to start thinking about this and having those conversations. So I'll send that out to you guys.
Awesome. I appreciate that.
Yeah.
I have one question. What about the times when you can't be sure about a patient's lifespan, right? Because just anecdotally, I've heard a lot of stories about patients being given, a 3-month window, and then they end up living for another 5 years or something.
Yeah. Great question, Logan. So don't ever use the phrase, I don't have a crystal ball. The amount of times I've heard surgeons say that stupid phrase makes me insane. Well, I don't have a crystal ball, so I don't know how long. Okay, cool. I get it. We're not predicting the future. I think we can say things like, I hope you have a really long time to live. I hope this is going to be 5 years of us together, but I'm worried it might not be. So they even train in these end of life conversations, I hope, I worry statements. So I've seen people live for 5 years with this condition or more, and I hope that's you, but I'm worried it could be much shorter, and I don't want you to miss out on time with your husband. I think that can account for that, where you're not saying you have 3 months to live. I probably wouldn't ever prognosticate that kind of specificity. You could say most patients live this long. And I'm worried you might be more along that group, but I hope it's not the case.
But if you frame their range of treatment options as if you don't think that they're going to live for very long, you're kind of biasing not treating the patient when maybe potentially treatment could prolong their life for a long time.
Totally. I think, Logan, that's where you start balancing the risks and burdens. So if there's a chance that someone could live longer with this intervention, and the intervention doesn't really cause a ton of suffering, I might say go for it. But if there's a small chance and it makes them so sick that they can't get out of bed, and what they want is in a month to go to their granddaughter's wedding, the risks and benefits seem totally out of whack. And it might be getting him to feel well enough to go to his granddaughter's wedding is more of a priority than, but if it's like, you can still go to the wedding because this treatment doesn't make you feel too shitty, let's go for it. Does that make sense, Logan? Like, it has to be framed around those immediate goals and long-term goals.
Yeah, it does make sense to me. It seems like it would just take a lot of time to kind of figure out how to manage these situations and feel comfortable doing it. But
yes, so that's why, Logan, we have to burn down the healthcare system as it stands and rebuild it together, and then provide time for you guys to have the conversations that need to happen. The fee for service, see someone for X amount of minutes, generate RVUs, be productive, be efficient, is so unhelpful, and especially for people approaching the end of life.
Do you think, I don't know if you meant this seriously or not, but do you think burning down the system is ever going to happen or realistic, or what are your thoughts?
So we know it's not sustainable as it stands. I think that COVID has exaggerated the problems that were already there, and we're having all these nurses and respiratory techs quit and find new jobs. And so I do wonder if maybe something's coming to a head in that way. And then my hope is that as we think about PT education, medical education, nursing education, part of my conviction is I'm training my future physician students how to be advocates, how to ask for change, how to buck the system, participate politically, I think the onus is on us and maybe people like Travis and others who are teaching to be like, we've got to ask for something else and kind of create a future cohort that they demand something else.
Yeah, I was going to say it has to start almost with the educational process. And I would argue even further back than even just the direct medical thing, because we have a culture where a doctor goes, I'm going to be a doctor because I get to have money and I'm going to cure people, right? So we have this whole thing. And so that's the problem with trying to burn it down, so to speak, is you have to be building while it's on fire.
Yes.
And that's a tricky fucking thing to do, right? Because you're using the same boards, unfortunately, oftentimes to build. So you have to have new boards. So we have to be creating steel boards. So while it's burning, we're building the steel that's not going to melt at those temperatures. And how do we do that? And that takes a whole long thought process. So it's not just what do I need to do at med school, but what do I need to do at this school? What do I need to do this? Yes, med school kind of warps people. And I've seen my friends go from altruistic individuals that wanted to help, to help, to I now have student debt and I have this other stuff, so I'm going to have to do this and I need to make money, right? And then once they're practicing, they're like, well, now I have to have a lifestyle that matches the other doctors who are made fun of in my peer group. So now I have to have these things, so I need more money to do that. So I've seen that course, but it starts early culturally with what those expectations of a physician is.
Totally. And the expectations of a physical therapist. So this starts in undergrad, I think, where it's not, well, I like science and the human body and I want to help people. I'm going to go into healthcare. All right, well, buckle up because you're about to see suffering. You're about to all this stuff that we don't tell anyone about. Then you graduate PT school and you're like, wow, didn't know I'd be dealing with all this. And so I think we start, and you all know it's high school, it's pre-K, like it's being born in America. Like there's a lot of things that are shaping how we see what it means to give care to other people. But yeah, that pre-PT, pre-health, pre-med track, oh man, powerful in terms of what we're communicating about what's important and what kind of training you need. So they should be saying, you're gonna need a bunch of philosophy classes so you could deal with human suffering. No pre-health advisor is telling you that, right? So like we got to start changing undergrad training too.
Yeah, I mean, I would argue that from elementary school, we need to be teaching kids how to think.
Yes.
I can look up on my phone all the fucking didactics I need.
Yeah.
Right. I need to be taught how to think, how to communicate, how to do things. We need to go back to kindergarten, because everything I need to learn in life, I need to learn in kindergarten, right? Because that's how you get along. That's how you communicate. That's how not to bite and spit and pee on people. And all those things are important qualities. And I'm not sure that we're getting it because we need to teach to a test and we need to have this, right? I mean, we've got kids doing calculus, right? In ninth grade. Why? Okay, well, maybe they're prodigious and they're going to go on to that. But otherwise, they now leave school going, well, I did a lot, but that skill set is not necessary in life, right? Or that technical stuff is only a tenth of what I'm going to be doing. I'm going to be doing all this other stuff because that's just the reality. But we're not helping people think and learn to live. We're just making people regurgitate didactics, and that does nothing.
Totally. That's why I hope, we walk away from being together today, realizing we need to burn down the healthcare system and the educational system. Start over. Yeah.
Hey, Nicole,
do you think? Go ahead.
Oh, sorry.
Too.
Oh, thanks, buddy. When we're talking about end of life conversations, I think something that's maybe potentially more applicable for PTs just at large is maybe like the idea that when people are dealing with injury, there is some kind of a end of life within their life. It's an end of a life of who they were into a life of who they're going to be. And sometimes we get really great things to happen where things do return or even come back to a higher level of function, or you surpass baseline, all the good stuff that makes us feel warm and fuzzy. But sometimes there's not. And I'm wondering if you would frame that conversation similarly or different, depending on if we're talking end of life as in mortality or end of life as in their existential existence of what they knew to be life prior to injury. Does that make sense what I'm asking, Nicole?
Yes. And Q, I love you. Yes, that is exactly right. That we can have multiple deaths throughout our lives. And if anybody read Afflicted, Heidegger talks about this, like death doesn't have to be like the cessation of my body, but we can have death of identity, death of the world as we formerly knew it. And that's terrifying. And would I frame conversations similarly? Absolutely. It would be, I hope that we can get you back to where you were, but I'm worried we can't. And that this is the way life is going to look. And how can we find meaning and make it as meaningful and peaceful as possible now that that old life is gone? I don't think people are having those conversations. That's a terrifying conversation to have, because it also means I've got the potential for that. I don't think we like to be vulnerable enough to be like, I'm looking at this guy whose life is so different, and that is so terrifying that I'd rather tiptoe around all that. Let's pretend that we're going to get his body restored to the way it was before. So yes, and that's such an insightful question, Q. And like, absolutely, we are skirting those conversations all the time. And those are ones we need to work on as well. Thank you for asking.
And then,
that.
yeah, no, I really appreciate your answer too. And then I guess the follow-up to that goes back, and I don't know if there's even a good answer to this, honestly. So I don't want you to feel pressure to give some, very awesome, nuanced answer that that really solves the problem. But then we were talking earlier about the social media campaigns and other things, and I think we all as clinicians struggle in the space of, well, if I tell somebody these things, and even if I frame it in a very good way where we're using, I really hope for you that we do get to this level. I am worried about these couple of things over here, that sometimes we still look like we are incompetent and unknowledgeable, that there are these Instagram, folks out there who can, apparently they can heal anyone, based on the advertising that they put out there. And it becomes very challenging on us, because then sometimes I feel that these folks come home, or I hear it from other family members that they say, oh, my clinician or my, healthcare provider said this. They don't know what the hell they're talking about.
Yeah.
Like, I'm going to go over here where I get more absolutist answers, even if it doesn't work. I don't know. I'm rambling a bit. I apologize, but maybe we can dig into that just a little bit.
Yeah. So hard to navigate that. I don't know. I suppose I can only speak for myself if I were a patient. If I had a clinician who said, I hope for this, I worry about this, this might be an uncertain trajectory, but I am committed to you and I'm going to try my very best to get the best outcome for you, I'm with that clinician. I mean, then again, if I was with one who was like, oh yeah, I could totally do that for you. I would be tempted by that, if I'm honest.
Yeah. No, that's perfect. I think you're hitting on just the basics of the foundation of how you frame it. Very caring, very from a place of like, I'm not absoluting anything on you. I'm not putting anything, labeling anything towards you or your situation. I'm just giving you the idea that I am a very caring healthcare provider with your best interests in mind. And I want to do the very best that I can for you, given all that I know, and I will do that for you. Yeah.
Totally. So it's trust. It's, do I trust you? And do you have my best interests in mind? And you could even say, you might see people out there who are going to promise a quick fix. In my experience, there's no quick fix here, but I'm so committed to getting the best outcome for you. That means Q is going to be my clinician forever, because I trust that more than a promise of a quick fix. That's just me. I'm sure there are patients who would think otherwise, but that's me. So, yeah, Joseph, I know you got to head out. Some of you guys are going to have to head out. That's no problem at all. But I know, Travis, you had something you wanted to add to.
I have two questions. The first is, so you mentioned philosophy classes for uned. So I'm teaching undergrad exercise science students who are going to be going into PT school. We have psychology classes for them. Some of them are mandatory, some of them are optional. I don't think that, like, they can take electives, but I don't know that we're recommending philosophy. Like, is that, like, I've taken some psych classes. I've never taken a philosophy class. Like, how do you kind of prioritize when they have so much to take?
Yeah.
Like, do you feel super strongly that philosophy is the thing versus psychology versus both? Like,
Great question. I suppose it doesn't matter. Like to me, it's, are you taking liberal arts classes that do what Paul was talking about, which is like teaching you how to think, helping you see that there's no right or wrong answers, that questions about mortality and being and suffering are core to being a human and then are saturated in healthcare. That's the thing we don't tell students. Yeah, being alive is hard. You got questions about mortality, suffering, meaning making, but then they're concentrated in healthcare because people are facing vulnerability or end of life. So that's where I think like those health humanities courses are where it's at, because it's people engaged in English, philosophy, psychology, religious studies, history, and then applying it to medicine. That's what I think is transformative for like a pre-PT student. So you gotta work with your colleagues to create some of those. And they're usually pretty popular.
yeah, well, for better or for worse, I'm teaching one of the psych classes. So it can be whatever I want. I'm not qualified to do it, but I'm passionate about it at least.
Yes.
So that's half the battle, right? My other question for you was, as you've gotten to like the end of your books, like when you're writing a book, you are kind of, you're saying, hey, I'm an expert on this topic because I've done the research and I'm making I'm telling a full story. Have there been situations where you've wanted to like explain something and you thought there was an answer to, like, oh, we must have figured this out. It's 2021, like we must have an answer for this. And have you been like surprised, like there is no answer to this? There are certainly like people talking about it, maybe not enough.
Yeah.
But do you have like, is there anything where you're like, I have a burning desire to better understand this because I think by 2021 we should know this and we just don't know it yet?
Yeah, so I suppose everything. So, what is it? Socrates says, the more you know, the less you know. And like the wise person knows that they know nothing. I feel that way all the time, except for things I feel convicted about, which is we should care well for patients. We should look at their suffering and walk into it. Are those opinions? I suppose, but I feel convicted about those things. In terms of knowing the answers, yeah, there's all sorts of things that I wish we had better answers for. And the more I think about it, the more I don't know. One example of that, Travis, would be like I used to feel very convicted that all physicians ought to care about the existential suffering of their patients and but then I kind of have learned like some are really bad at it and probably shouldn't even be having those conversations and maybe need to like defer to one of their colleagues. But I'm also glad they're like a great cardiac thoracic surgeon or something. I've been a little bit more open to allowing for that because that's just the reality of the situation. But I think we can change that by saying we're looking for different applicants to med school and PT school. We just got rid of our prereqs for applying to our School of Medicine. And so, yeah, we encourage organic chemistry and all that stuff that we used to encourage, but now we also encourage humanities. So I think there are things we can do to start saying, or like at your guys' PT schools, we're looking for this candidate. We want you to have thought critically about this or spent a year going and doing that. We can change that. We don't, but we can. And then we can stop saying way downstream, oh, that cardiac thoracic surgeon should give a shit about his patient. Maybe we should have told that person medicine's not really for them. So rather than trying to convince people here, I think we need to change the systems down here. I hope that makes sense, Travis, because my thought process has changed on that a little bit.
Yeah, that's super helpful. And I can relate to that. Like I had GI surgery years ago and I picked the surgeon who I thought was going to do the surgery best, not the one who I thought was going to be able to talk to me the best.
Yep.
And like ultimately that maybe was the wrong choice because I had complications and like he couldn't handle that, when I was in the hospital for 3 weeks. So, but I
Yeah.
still like, he did a good job with the surgery, he like botched the management afterwards. And
Right. See, and that's the thing that is also that soft skill of managing afterwards, or of listening to you, or taking this complaint seriously, or I'm in pain that this doesn't seem right.
Yep.
Those are soft skills. And that's why the surgeon has to be both a good, authentic listener, compassionate, concerned, and technically skilled, because the technical skills mattered for the 6 hours that you were in the OR. And then those don't matter anymore. So you better have those other skills. And we need to be looking for future clinicians who've got the whole package.
yeah.
Yeah, go ahead, Travis.
I've been meeting, I just started my job and I've been meeting with the students, trying to just get to know them and see how I can like help them and advising them over the next 3 years. And some of them, I'm like, these students, I know they're only sophomores, but they can't even talk to people. Like, how are they going to function as physical therapists in, they're in an accelerated program. So 4 years from now, like, can they make the change? And I'm thinking back to like, well, when I was 20 years old, like, could I talk to people? So it's interesting because we're making people decide, this is another conversation, but we're making them decide at 18 years old that they want to be physical therapists in 6 years.
Yep.
Is that really the right thing to do? I don't know, but that's how it is. So how can we help these students succeed the best? And, identifying those people who are going to need to learn to talk to people and getting them, like helping them break out of their shell.
Yep. And Travis, I think it is not the right way to go. Like 18-year-olds should not be making the decision. That's just my personal opinion. When I was 18, I had no brain. I didn't know who I was. Like, no.
Yeah, I wrestle with it because I walked into this program and that's our calling card, is that we can get you to a DPT in 6 years. And I don't know if I agree with that approach to it, but that's why people are coming to us.
Yep.
So, well, this is the hand we've been dealt. Now, how can we make the most of that 6 years?
Oh, I feel you. Totally. But I'm glad they have you. You're being very thoughtful about it. You're going to have colleagues who don't even think twice about that. So
yeah,
I'm glad they have you, Travis.
Well,
That's
thank
great.
you.
Yeah. Yes. Okay. I'm sorry. This happened last time. We're like 21 minutes past where we're supposed to be. But if anybody has final thought, question, I've had a lot of fun. I could do this for a long time. So
I'm just appreciative that you brought this context into a physical therapy perspective. I think that like I saw the headline come across my email. I was like, I'm definitely jumping in on that.
oh, good, Daryl.
Yeah. So yeah, I just appreciate that you're here.
I second that because nobody else talks about this
Yeah.
in any venue that I've been in. And so coming across your work, I'm like, wow, we need to engage with Nicole and her area much more.
Thank you, Travis. Thanks, guys, for saying that. The PT world has been like my new world. I just gave the keynote at the Educational Leadership Conference with APTA, your guys' group, which was, oh my God, people were so generous and receptive. And I'm going to be giving a couple more talks on this like PT circuit, which is super fun. So you guys are just the best. And the more that I can be engaged in the physical therapy world, the happier I am. So just thanks for inviting me too. And thanks again, Chris. This is super fun. So thanks for being here on a Saturday morning. And if there's ways we can engage in the future, just let me know.
Perfect. Thanks, Nicole. And I appreciate you joining this when you're out in California.
Of course. Happy to do it. You guys are awesome. You guys have a great weekend. Okay.
Bye.